Dear colleagues, this presentation is presented for clinical key for electrical stimulation in physiotherapy and rehabilitation project. The project partners are Pamukkale University, University of Craiova, Hatay Mustafa Kemal University, Başkent University, Süleyman Demirel University, Schley State of University Applied Sciences, Burdur Mehmet Akif Ersoy University, and National Physiotherapy Associations. I am Özlem Yürük from Başkent University. The subject is electrical stimulation for patients with disuse atrophy. Skeletal muscle is a crucial tissue for movement, metabolic hemostasis, and thermogenesis. It makes up approximately 40% of the body weight and 50% of the total protein. Muscle atrophy is characterized by weakening, shrinking, and decreasing muscle mass and fiber cross-sectional area at the histological level because of immobility, aging, malnutrition, medications, or a wide range of injuries or disease. Muscle atrophy results from an imbalance between protein synthesis and protein degradation. Disuse atrophy is a common cause of muscle atrophy and can be local or general. Bed rest is frequently prescribed for critically ill patients because it is assumed to be beneficial for preventing complications, conserving metabolic resources, and providing patient comfort. Furthermore, higher levels of physical activity in critically ill patients are assumed to be impractical or not feasible. Bed rest is prescribed for several clinical conditions, including after surgery, acute flares of rheumatoid arthritis, tuberculosis, acute myocardial infarction, and acute low back pain. Bed rest can cause several complications, including disuse atrophy, joint contractures, thromboembolic disease, insulin resistance, microvascular dysfunction, systemic inflammation, atelectasis, and pressure ulcers. Local immobilization is generally induced by casting or bracing, which isolates muscle disuse in a single muscle or muscle group. Bed rest causes a greater decrement in muscle mass than a local immobilization due to systemic factors. This demonstrates that interventional strategies should not only focus on preventing muscle loss during a period of disuse, but also aim to attenuate the decline in metabolic health that occurs during disuse in a bed rest model. Two key anabolic stimuli for skeletal muscle tissue are muscle contraction and food intake. Muscle atrophy can be delayed, prevented, and sometimes reversed with treatment. Physical activity, exercise, and electrical stimulation are used in physiotherapy and rehabilitation programs for patients with disuse atrophy. The physical activity can already preserve skeletal muscle mass and strength during a period of disuse. However, an increase in voluntary physical activity is not realistic due to limb immobilization or general weakness. Electrical stimulation is an optimal safe approach instead of physical activity. Before clinical decision-making for physiotherapy and rehabilitation program and electrical stimulation, physical examination is essential. Firstly, a review of the medical record can help identify the patient's medical history and precautions. Physiotherapists evaluate muscle strength, range of motion, anthropometric properties, endurance, posture, fatigue, and pain in patients with disuse atrophy. Functional tests, for example, balance tests or gait tests, are also performed for recovery. Electrical stimulation has effects on tissue level and clinical function level in disuse atrophy. Neuromuscular electrical stimulation, functional electrical stimulation, and magnetic field stimulation can be used for patients with disuse atrophy. Muscle contraction is one of the more potential stimuli that can increase muscle protein synthesis. Although performing voluntary physical activity is undoubtedly the most effective intervention to preserve muscle mass, it is often impossible to maintain a certain level of voluntary physical activity during periods of forced bed rest or limb immobilization. In such clinical conditions, neuromuscular electrical stimulation could be applied to induce contractions and stimulate muscle anabolism. A single session of high frequency and high intensity acute application of neuromuscular electrical stimulation has been demonstrated to increase muscle protein synthesis by 28%. This positive effect of neuromuscular electrical stimulation on muscle protein synthesis rates translated to preservation of muscle mass during 5 days of leg immobilization in healthy young individuals. However, this was not accompanied by any beneficial effects on muscle strength. This result is in line with other studies that demonstrated the efficacy of electrical stimulation in preventing muscle loss in various clinical conditions. Importantly, these findings also support the use of electrical stimulation in intensive care unit patients. Neuromuscular electrical stimulation can increase muscle protein synthesis rates in elderly and basal phosphorylation in intensive care unit patients. It was shown that neuromuscular electrical stimulation could also suppress muscle protein breakdown. These data underline the effectiveness of neuromuscular electrical stimulation in disuse settings. Although neuromuscular electrical stimulation is clearly an effective tool for disuse atrophy, little information is available on how it can be effectively applied. To specify its impact on skeletal muscle tissue, the long-term effect of high-frequency electrical stimulation has been investigated in a fiber type specific manner. Increases in both type 1 and type 2 muscle fiber size have been observed in healthy individuals and patients following multiple sessions of electrical stimulation training. Although it is clear that high-frequency electrical stimulation exerts its greatest effects on type 2 fibers, there is a discrepancy as to whether this is located predominantly in type 2A or type 2B fibers. In situations of muscle disuse and clinical illness, it has been shown that neuromuscular electrical stimulation leads to a relatively greater impact upon type 2 muscle fiber size compared with type 1 muscle fiber size. The specific effect of neuromuscular electrical stimulation on type 2 fibers may be due at least partly to their more superficial location than type 1 fibers, making them more sensitive to the stimulus from the surface electrodes. This makes neuromuscular electrical stimulation a highly relevant interventional strategy in various situations where individuals suffer from predominant type 2 muscle fiber atrophy, such as following injury and during immobilization, clinical illness, or aging. Many studies have examined the efficacy of neuromuscular electrical stimulation on one specific muscle. An important next step would be to target multiple muscle groups to maximize the relevance of applying neuromuscular electrical stimulation in clinical practice. Although the quadriceps femoris muscle is one of the most susceptible muscles to atrophy, larger muscle groups such as hamstrings, gastrocnemius, and back muscles would likely benefit from the treatment of neuromuscular electrical stimulation. And also, electromagnetic field stimulation produces the stimulus at a deep level, avoiding skin sensation. Therefore, the use of repetitive magnetic stimulation of muscle is increasing. An experimental study showed that the magnetic stimulation preventing atrophy resulting from 6 weeks of immobility in rats. The effects of electrical stimulation in patients with disuse atrophy are prevent atrophy by reducing muscle protein breakdown, increase peripheral muscle strength, regulate peripheral circulation, and improve exercise capacity. And here is the parameters for electrical stimulation for muscle strengthening in general immobilization, for example, bed rest. Neuromuscular electrical stimulation parameters can be determined according to the specific needs and reactions of each patient rather than establishing a uniform protocol. However, a general outline of the electrical stimulation protocol is shared. The treatment is directed to lower extremity muscles during bed rest. In neuromuscular electrical stimulation, Russian current, high voltage pulse galvanic stimulation, or Faraday current can be preferred. It's recommended to prefer biphasic, symmetrical or asymmetrical, or twin peak waveforms in 35 and 50 Hz frequency ranges with a stimulation duration between 100 and 600 microseconds. In the neuromuscular electrical stimulation application, high repetitive muscle contraction is considered. After contractions, intervals are adjusted according to the patient's fatigue level. The obtained data emphasize the determination of the most appropriate contraction and relaxation rates for the patient without causing excessive fatigue in the muscle. It is recommended to have a variable amount of a visible but clear contraction to be increased up to the patient's maximum tolerance. The total treatment duration varied due to the immobilization period. However, 4 or 8 weeks are required for muscle strengthening. It has been reported that frequency of treatment can vary between 2 and 7 per week, and the duration of the treatment session can be vary between 15 and 60 minutes. Electrode placement is decided according to the muscles to be stimulated. Electrodes are placed parallel to the fibers of the limb muscles. Stimulation can be performed unilaterally or bilaterally. Here is electrical stimulation for endurance training in disuse atrophy. These parameters are same with the muscle strengthening parameters. Only the amplitude can be set 25 or 50% of maximum voluntary contraction, and the treatment duration can be 15 or 30 minutes. Neuromuscular electrical stimulation can prevent bone and cartilage deterioration in short-term brace-immobilized limb of rabbits. The electrical stimulation also prevents muscle atrophy during the bracing period in humans. The stimulation protocol is the same for bed rest patients. However, it is necessary to open windows over the appropriate areas of the brace to assess electrode placement. A pen electrode should be used as an active electrode. A larger passive electrode should be placed near the cast or brace. Neuromuscular electrical stimulation can be performed 2 or 5 days a week during immobilization period. Since pressure over bony prominences will occur during the neuromuscular electrical stimulation, care must be taken with casting techniques before combining electrical stimulation and casting. And functional electrical stimulation, cycling in bed, is used an alternative stimulation technique combined with exercise. In the intervention, 4 electrodes are positioned at each extremity of both quadriceps femoris muscles. A rectangular pulsed biphasic current is used, and the intensity is modulated to obtain a palpable muscle contraction. The other electrical stimulation parameters can be identical for all patients. These settings are based on the usual electrical stimulation protocols. During cycling, a computer controls the stimulator. The software ensures the muscle contractions are induced at the appropriate pedal angles during the knee extension. Following a 2 minutes warm-up, the load can be increased according to the patient's tolerance. The patient cycled at a frequency of 50 or 60 rotations per minute for 20 minutes. Functional electrical stimulation cycling can be performed 7 days a week. Here is the functional electrical stimulation cycling parameters for disuse atrophy. The current type or waveform is pulsatil or burst modulating alternating current, or symmetrical biphasic or asymmetrical biphasic currents. The pulse or cycle duration can be set at 100 or 600 microseconds. The amplitude should be comfortable or maximum palpable contraction. The frequency is between 30 or 50 hertz. And the stimulation duration is 20 or 30 minutes. We can, as mentioned, we can use 4 electrodes on quadriceps muscle bilaterally. There have been a few studies on magnetic stimulation for disuse atrophy. Therefore, the practical, the generalizability of the protocol is not possible. In stimulation, the coils are applied at the point between the upper third and lower 2/3 of the vastus lateralis, the optimum location for eliciting a contraction response. The intensity and frequency of stimulation are adjusted according to the patient's tolerance and the performance of the equipment. Stimulation follows a cyclical pattern of 2 seconds on with contraction elicited by burst of tweets and 4 seconds off, repeated over a period of 15 minutes on each time. Stimulation can be performed at 1 or 1.5 or 2 millitesla capacity and 15 or 40 hertz frequency. Neuromuscular electrical stimulation can be used in various conditions. Following anterior cruciate ligament reconstruction, restricted weight bearing and immobilization result in thigh and calf muscle atrophy and weakness. Electrical stimulation implemented during the early rehabilitation stage is effective in maintaining and increasing muscle thickness and strength in operated limb. Recovery of the quadriceps femoris muscle strength and function after total knee arthroplasty is suboptimal, which predisposes patients to disability with increasing age. Electrical stimulation effectively attenuated the loss of quadriceps femoris muscle strength and improved functional performance following total knee arthroplasty. And electrical stimulation in advanced diseases. It has been shown that neuromuscular electrical stimulation improves endurance and muscle strength and cross-sectional area of the thigh muscle in patients with chronic heart failure. Therefore, neuromuscular electrical stimulation is an effective option for passive exercise. In people admitted to either an intensive care unit or a respiratory high dependency unit, neuromuscular electrical stimulation combined with conventional exercise may accelerate the attainment of a functional milestone. Regardless of whether it was applied alone or together with exercise training, electrical stimulation appears not to increase the risk of adverse effects. Also, we can use electrical stimulation for venous thromboembolism. Electrical stimulation thought to be effective as a mechanical method of prevented blood clots in legs. A Cochrane review aimed to identify available evidence on the effectiveness of neuromuscular electrical stimulation compared with other methods in preventing the formation of unwanted blood clots. Evidence shows no clear difference in the risk of deep venous thrombosis between electrical stimulation and alternative methods of prophylaxis, but suggests that neuromuscular electrical stimulation may be associated with a lower risk of deep venous thrombosis compared with no prophylaxis and a higher risk of venous thrombosis compared with low-dose heparin. Rady et al. In geriatrics, electrical stimulation in geriatrics. Rady et al. Studied the effect of neuromuscular electrical stimulation and protein supplementation in elderly individuals who were taken to full bed rest for 5 days. Electrical stimulation was applied bilaterally to the quadriceps femoris muscle 3 times a day for 40 minutes. Neuromuscular electrical stimulation could prevent muscle mass, but not could prevent the function loss. Although electrical stimulation and protein supplementation are effective in preserving muscle mass in elderly individuals receiving inpatient care, physical activity is required for the continuation of function. And magnetic field therapy in patients with disuse atrophy. Magnetic field stimulation represents a feasible, well-tolerated, safe therapeutic option for different pathologies. However, very few studies have investigated the effectiveness of magnetic field stimulation in patients with disuse atrophy. Magnetic field stimulation was a well-tolerated therapeutic intervention that did not enhance muscle oxidative stress while increasing the size of slow twitch fibers. Bustamante et al. Investigated the effects of quadriceps femoris muscle magnetic field stimulation in several patients with COPD. The control group followed with clinical monitoring. Treatment group underwent quadriceps femoris stimulation of both lower limbs. The magnetic field stimulation was applied in 15-minute sessions with the intensity and frequency of stimulation adjusted according to the patient's tolerance. In several patients with COPD, magnetic field stimulation was a well-tolerated therapeutic intervention which didn't enhance muscle oxidative stress while increasing the size of the slow twitch fibers. And as conclusion, in this video, the purpose of electrical stimulation for patients with disuse atrophy, application methods, and literature studies are discussed. Neuromuscular electrical stimulation, functional electrical stimulation, and magnetic field stimulation can be used for patients with disuse atrophy. Neuromuscular electrical stimulation has beneficial effects on improving peripheral muscle strength and functional capacity without causing the metabolic load in individuals with disuse atrophy due to bad rest. However, the use of neuromuscular electrical stimulation for local limb immobilization is limited and has only been mentioned in past studies. The effect of functional electrical stimulation and magnetic field stimulation are not clear for disuse atrophy because the number of studies is limited. Further studies can be conducted on disuse atrophy to determine the effect of electrical stimulation. Thank you for your attention.